Hey, good morning or good afternoon, depending on where you're at. This is BFR Tuesday, and my name is Cara, and I'm going to be taking you through. I do this every Tuesday, looking at new research and different topics with BFR, questions that I get on Instagram or Facebook and or in emails. So today, what we're going to talk about is a new study, which I've already shared with you in the comments section. So, and this was a huge study looking at possible mechanisms for the hypoalgesia we get with using BFR and exercise. So what we know is that using BFR, well, just let me preface that. Using exercise alone has been shown to have a tremendous effect on pain. And we can get a pain reduction by doing high intensity exercise, but some people can't tolerate the intensities necessary for that. So BFR is a nice way to create a reduction in pain to then improve the ability for people to move better and feel better. So what I'm going to do now that it's 101, I would download this full text article, or I'll just say article. So download this article so you can follow along, or you can read it later. I'm not going to go deep dive into this. I try to keep these about 15 minutes because I have patience in a bit, but I will chat about it. So I'm going to switch over and share my screen. All right, and here's this huge study. So I highlighted some things which I thought were interesting. You're going to have to go through and read what interests you and then look at some of the references for further research. But exercise-induced hypoalgesia is characterized by a reduction in pain sensitivity following exercise. And EIH would be the abbreviation. This manuscript is to discuss the mechanisms of exercise-induced hypoalgesia. And it appears that there are several potential mechanisms, including opioid and endocannabinoid-mediated pain inhibition, conditioned pain modulation, recruitment of high-threshold motor units, exercise-induced metabolite production, and an interaction between cardiovascular and pain regulatory systems. It looks like that a high level of intramuscular stress in the exercising muscle generated by blood flow restriction, including hypoxia, accumulation of metabolites, accelerated fatigue onset, and ischemic pain lead to the EIH. Anecdotally, we see this in the clinic all the time. I will put somebody without that doesn't have chronic swelling, like large amounts of swelling, more than 2 inches in a limb compared to the opposite side. I'll immediately get them doing exercise using BFR to try to reduce their pain levels. This is a nice review about EIH. It has a lot of the references that if you want to look closer, but it looks like this pain desensitization following exercise is not limited to the exercising limb and is observed in non-exercising muscles in remote areas of the body and to a smaller extent than the exercising muscle. So for people with chronic spine pain, it's great to put BFR on them and have them walk or have them bike or have them do something that's active to try to create that systemic hypoalgesia. Numerous references for this, not as many as I would like, but enough. And also I see it enough in the clinic to know that it's a real deal. BFR becomes in handy because it's known that most of this hypoalgesic effect, hyperalgesia, I guess, is better with higher intensity exercise. And so the people that cannot tolerate those high intensity exercise, BFR is a nice way to achieve the similar results. BFR exercise has been shown to reduce pain across the training program in a range of clinical conditions. Here's some references for that. And it looks like this pain reduction is good for about 45 minutes. So you can get them moving in a better environment for up to 45 minutes during your session. It now goes into many of the mechanisms of exercise-induced hypoalgesia, activation of the endogenous opioid system, cannabinoid-mediated mechanism, interaction of cardiovascular and pain regulatory systems. Again, I'm not going to read through all this, but if this is of interest of you, please, that's the reason I shared it with you, so you could take a look at it. Conditioned pain modulation, high threshold pain unit or motor unit recruitment, exercise-induced metabolites, all the things that occur with BFR. So if you look at the overview of possible mechanisms, you're looking at stimulation of group 3 and 4 afferent fibers, increased pain or discomfort, activation of opioid and endocannabinoid systems, increase in heart rate and blood pressure, baroreceptor stimulation, triggering of descending inhibitory activity. So this is all what BFR is doing. Early onset of fatigue, preferential recruitment of type 2 fast twitch fibers, stimulation of group 3 and 4 afferent fibers, increased pain, discomfort, conditioned pain modulation. In this section of the study, it's talking about, or the article, it's talking about the possible mechanisms. Here is the opioid and endocannabinoid system. Third potential, BFR exercise may trigger hypoalgesia in the early preferential recruitment of high threshold motor units. So lots and lots of different mechanisms. And in conclusion, we hypothesize that several mechanisms consistent with prolonged high intensity exercise may drive the hypoalgesia response observed with low intensity BFR exercises. These are likely triggered by the level of stress in the exercising muscle generated by BFR, including hypoxia, metabolite accumulation, early onset of fatigue, and ischemic pain. So I think I'm going to close this out and stop sharing. I think what's really important for us to remember is that we use a lot of manual therapies, at least I do in the clinic: dry needling, cupping, active release technique, tooling, scraping, manipulation, voodoo flossing, shockwave therapy, all these things to try to reduce the pain. So if somebody is in discomfort, which most people are that come to see me, I'm trying to do something to improve range of motion, decrease their pain, enough to exercise more. That's the whole goal of any of my manual therapies. And so if we can do that, then we combine that with exercise-induced hypoalgesia, we're going to get these longer bouts of time when people are not in pain so they can move better. And of course, my philosophy is that the more people are moving in a safe and effective manner, the more that we can increase their capacity beyond their physical demands that are applied to them, whether that's in sport or just in life, the more pain-free and the more active people will be, the healthier they will be. So it's a loop, it's a whole loop. So get the pain levels down, exercise them to continue to get the pain levels down, give them home exercises to help get the pain levels down, improve their capacity to meet the demands of their life and their activities. Does anybody have any questions about this study? I see at least a couple of people have downloaded this Hughes article for a review. Any questions at all? Oh, I got one. Okay, let's see. Okay, unrelated question. We are taught in school that areas with greater oxygen supply will have a better chance of healing. Sure, that makes sense. Why would you decrease the blood flow supply in areas that are healing? Okay, so Courtney, it's a great question. So when we're looking at using BFR, it's only for short bouts of time. So we're looking at when we do exercise, it's only about 6 minutes and 30 seconds if you're doing a strength or hypertrophy. So we're not talking long bouts. We're not decreasing oxygenation for long periods. It's very short periods. And the benefits is that you're mimicking high intensity exercise. So there are some things that we don't fully understand about how our body's responding to these injuries. And part of it is that the body thinks it needs to repair itself as quick as possible so it can run away from saber-toothed tigers and dinosaurs. And there's a response when we're in the hypoxic environment that stimulates these mediators to help increasing pain, one of those being growth hormone. We stimulate growth hormone, we have plenty of vitamin C in the system, and we improve collagen synthesis. We've seen that with exogenous growth hormone stimulation for ligament healing, especially in ACLs. So although I agree with you, we don't want to be in a hypoxic environment for long periods of time. We're only creating temporary bouts of hypoxia. Now, in addition, it's not like we're exercising at 100% limb occlusion pressure. We're exercising at a partial limb occlusion pressure to mimic high intensity exercise so we can improve capacity to meet demands. Hopefully that answers. Do I have a protocol for ACL rehab? I've been getting questions a lot about protocols. Oh, you're welcome, Courtney. Hopefully that helps. I try not to beat around the bush. Hopefully that helps. I fight about writing protocols, and the reason is every patient is different. What somebody can tolerate today versus yesterday. But I'm getting convinced that I do need to write some protocols with BFR for some of these different conditions. Now, maybe next week, what I'll do is talk about ACL protocols and what to do for them, especially prior to surgery, right after the day of surgery, immediately post-surgical, and forward, so you can get an idea. And I think you're right. I think I need to write some protocols. I try to teach frameworks because every patient is different. Every healing environment is different. Every clinic is different. Exercises kind of maintain the same as what you're currently doing. You're just adding cuffs to it and keeping the intensity low. But I will work on that. Any other questions before we call it a Tuesday? All right, great. If anything comes up, you can always email me. I am ed@edlacara.com. And I'll talk about ACLs next week and see if I can't put at least some mini protocols together to help guide our thought process on how we approach them. Thank you guys so much, and enjoy the rest of the week and your Labor Day. Next week will be, we'll be in September. It's amazing. All right, have a great day.